All these lenses are available. I think the cost,
Yes, sir, it is available and it costs somewhere around 16,000 per pair. 16,000.
yeah.
Yes, sir.
There was one question. Yeah. Can you come down to the mic, please?
So the question is to all three panelists. Would you start these myopia control glasses as a monotherapy in the beginning? Because Dr. Lillian presented her cases of add-on therapy. So what is your opinion about starting them as a first-line therapy instead of drops?
Yeah, probably we'll start with Dr. Leah. Yeah.
Thank you. I think that's a very great question from Dr. Tamaye from Pune, because whether do we institute combination therapy right from the start? The short answer is yes, we do, especially for patients who come into clinical practice with significant progression, high myopia, and several other risk factors such as parental high myopia with even complications such as retinal detachment. In such cases, we do not have time to lose to start monotherapy right from the start and adding on and let them have a chance to have progression. We just start with combined therapy and monitor and see how they are progressing with this treatment.
Yeah, I also kind of agree. If you have a high risk characteristics of the patient, when we say high risk, parental history of very high myopia, child sibling is high myopic, and then the child's age is somewhere around 4 or 5, you still cannot start probably pharmacological. Probably there we can start optical. Maybe when the child is getting to the age of 5 or 6 years, we can add. And also, there is one more modification. You can also go for higher concentrations of atropine. So these are the 3-4 things we need to think. But primarily at Teleprasad, what we do is if patients has a peripheral hyperopia component, then we go in for more of a defocus glasses. If they have a pure axial, then we will do more in terms of pharmacology. That's a very short customization I'm explaining here, but there are exceptions. So how many of you in the audience manage myopia progression? Show of hands, please. Okay. So I think in 2025, there should not be any reason that any of this combination of treatment or monotherapy should not be instituted for the myopia patient. So it's very important that we explain the parents and explain the clinicians. There are options to control the progression. Yes, sir.
Is there any problem with 0.25 atropine, like pupil size, because of the pupil size?
Which concentration you are talking about, sir? 0.0?
0.25.
The pupil problems are mainly with the higher concentration. What we generally use in India is 0.01%.
Yeah.
It usually does not cause. When you say usually, more than 99%. There are some case reports.
No,
some
I'm talking
glare.
of 0.025.
Yeah, not much, sir. I think you want to answer?
Yeah,
Point.
sure, Dr.
Yeah.
Ramesh. So basically, based on our clinical experience with 0.025, it is generally very, very well tolerated. Although it is close to 0.01, but less than 10% of the children do experience some form of side effects. However, they are tolerable, which implies that they do not need any photochromatic glasses or any bifocal progressive lenses to help them overcome these side effects.
Yeah, it again depends upon which location you are, what's the color of the iris. If you go into Caucasians and whitish iris, it can cause. But generally, we don't see that. Yes, please, there are one by one.
So what is the range of myopia? Like in one of the slides, you show 1.5 to 6 diopters was the study. So what is the bottomest, like 0.5 up to 6 or 7, 8? Which patients we should advise? Like, is there any golden rule?
There is
Okay,
no range of myopia where you should not treat.
Okay.
Any myopia which you see a progression which is documented, that person needs treatment. I also want to caution everybody that you have to look into only pure axial. It does not be useful in keratoconic myopia or any subluxated. So any range we can start, but the thing is you have to see a progression in them. So you could take any of these measures. And it's not that, okay, after 10 years I will not use any anti-myopia strategy. You can use that as well.
What is the upper age limit of the patient?
You can, there is no upper age, sir. We are seeing more and more patients beyond 18 years also. They are coming up with progression. But generally, most of the patient at around 5 years or 6 years, we start this process. And it's a very long-term process. It's not that for 6 months you use and then stop it. It can go to 4 years or 5 years once you start it. So there is no real cutoff. Go ahead, please.
Sir, is there any cycloplegic effect seen in on using atropine 0.01%? I have seen one case a patient was not able to see the near.
Yeah, that's what I said. Very rarely near vision can be affected. Very rarely 0.01% or 0.1% of the patient can have. And there are case reports where it can lead to even convergent spasm, or there are very few reports that there are accommodative esotropia. So these concerns are there, but generally it will not cause. It's pretty safe dosage or a concentration of atropine to use in these children. We'll go ahead with that gentleman and then we'll come back. Yeah, you can go to the mic. Yeah.
Good morning, sir. Sir, you had mentioned the behavioral modifications.
Yes.
Such as reducing screen time and increasing outdoor time. So how effective is this? And secondly, the thing is sleep, respect the sun you had said. That means follow the circadian rhythm, go to bed early, avoid exposure to ambient light at night, and also they say switch off the bed lamp at night. So how effective are these in slowing down the myopia progression?
Very good question. The best evidence is available in terms of modification of lifestyle is before the onset of myopia. Having said that, even after the onset of myopia, one should not forget the behavioral modification. As I said in my presentation, many people say, okay, I'm using this anti-myopia strategy, let me close the behavioral. That still continues. And what you said, that light and the posture, all that has to be good. If somebody, most of the kids will have studies even after 7 o'clock. It's not that they will switch off at 6:30 or so. So 2-3 things we need to be remembering. One is a good lighting system, good posture, and many people sleep and lie down and read. That way it can decrease the distance of the, your reading distance. That is also not good. So you need to have a healthier habit for this reading also.
Sir, after LASIK operation for myopic shift, should they be used?
I don't think so. We have evidence. You are talking about more than 20 years of age.
Yeah.
So
After
probably, I don't know, maybe there is a scope for orthokeratology, because it all depends upon what is the corneal thickness, lot of factors. But I don't think so there is much evidence in those cases.
Okay, thank you, sir.
I think because of time factor, we have to close here. I'm sure there are a lot of questions. We will be available outside. We can answer some of those questions. Thank you very much for the session, and thank you for the speakers. Thank you very much.